and Dr. Akbar, neurologist, who is going to speak on autoimmune encephalitis. I think we'll go directly to the topic. Encephalitis, all of you know, that is mediated by viral infection. But recently, because of the development of newer biological markers, they have found even treatment for encephalitis. And it's very appealing for the clinicians because immunotherapy has a role in the management of encephalitis. So discussing with Dr. Akbar that there is a scope for treatment of encephalitis because of the recent development in immunotherapy, which is being used in higher centers like Astor Medicity. Over to you, sir.
Yeah. So first a disclaimer, I have no relation or no interaction with the person there, right? Okay. So whenever we say encephalitis, by WHO we mean when a child has a fever and altered sensorium, right? That is an acute encephalitis syndrome. So I'm sure all of us in the hall are aware of the condition called autoimmune encephalitis. Do anybody know when we came across such a condition before? Right. So like we have autoimmune conditions affecting your general systems, like we have lupus erythematosus, we have autoimmune conditions affecting the GIT, ulcerative colitis, Crohn's disease. We have autoimmune conditions affecting other systems and joints. We can have autoimmune conditions also affecting your CNS. How common it should be, and why should I come and talk here about autoimmune encephalitis? Do we think it is common, or do we think it's very rare? You think it's rare? Do we think it's common? Is it as common as herpes encephalitis? Or is it as common as enteroviral encephalitis, or is it rare than herpes encephalitis? Okay, you'll be surprised to know the biggest California encephalitis project told that after Adam, the commonest encephalitis that we come across in children is NMDA receptor encephalitis, which is much more common than herpes encephalitis. Okay, so whenever we say encephalitis, we are interested in starting acyclovir, thinking about herpes encephalitis. Herpes encephalitis can also coexist with other autoimmune encephalitis. So when I say autoimmune condition, if I forget the brain, if I think about nerves and muscle, what condition comes into our mind? Any PGs? Autoimmune muscle condition, autoimmune nerve condition. Myasthenia gravis, correct? And autoimmune nerve condition is Guillain-Barré syndrome, correct? Right. So people always thought that autoimmune muscle and nerve, yani peripheral nervous system conditions were much common than autoimmune central nervous system conditions. That was the dogma. So if I take overall, if I want to include central nervous system, peripheral nervous system, muscle, epilepsy, movement disorder, up to 1/3 of all pediatric neurological conditions can have some immune basis, which means if I'm seeing 10 children in my OPD, 3 of them can have some of your autoimmune conditions. It is common, right? It can affect any part of the neuroaxis, right? From neurons to dendrites, to neuromuscular junctions, to muscle, to nerve, and the CNS. But here we are discussing about autoimmune encephalitis. So my theme was to tell one interesting case, to give just an idea, to tell that how did it start. There is an interesting story behind it, how many years we are into this entity called autoimmune encephalitis, how does it get modified, and when to suspect. So the fourth point and the fifth point is important. When would you suspect clinically? Clinically, there are definitive criteria and definitive clues that a child can have autoimmune encephalitis rather than viral encephalitis. So one case to begin with. This was a 12-year-old boy. He had 1 month of funny illness where he was having abnormal behavior, visual hallucinations, and fear. He had fever and vomiting for 2 days, and then he had abnormal movements which were in the form of twitches. If you carefully focus here, around the abdomen, you can see some twitches over there, muscle twitches, right? Again, the video comes. You can see some funny twitches going around all around the muscles. He had abnormal sensorium and jerks, and he had altered sensorium with twisting postures and encephalopathy for 12 hours. So we have a child with 1 month of illness, 2 days of worsening, right? So what can we suspect? His behavior has been changed for a month. Can we suspect viral encephalitis? Because he had 2 days of fever and vomiting, and he's having seizures, he's having these jerks all throughout, he's in encephalopathy. Okay, so story is that I did the MRI is normal. I did the CSF is normal. I did ammonia, metabolite, lactic acid, uric acid, metabolic screen, normal. Okay, I did a nerve conduction study, normal. So where do we stand? Everything is normal. MRI normal, EEG normal, LP normal, everything is normal. Even EEG is normal. So where do we stand? So this is what happened. In pediatric neurology, if MRI normal, EEG normal, we get really stuck. These are the basic first line investigations. So where do we stand here? So now, history, went back to the history. I asked the family appeared a bit dysfunctional. So these were young students, 12-year-old. So any clue? Okay, a 12-year-old boy who was having lot of problems with the mother and the father for so many 6 months. He's been aggressive, he wants temper tantrums, he has low threshold, he wants everything. Right? Then we had his cousins. So one cousin slightly came and told, sir, this child has a habit of smoking. Okay, so this was the first clue. Right? Then we understood, talking to the cousins, that he did liquid hookah ingestion from Dubai. Right? So this muscle fasciculations and twitches with autonomic symptom was actually a symptom of poisoning. So the final diagnosis was glucosamine with liquid nicotine ingestion. We couldn't prove because by the time we could do, he had responded. So that typical phase of that toxemia, toxidromes are settled, and he is now doing better with psychology and psychiatry follow-up. The idea behind this is that whenever we say encephalopathy, we think about infection, but there is also toxins. Right? There is also toxins. There is also autoimmune encephalitis. There is also inflammatory brain disease like vasculitis. There is demyelination disorders, and there is metabolic disorders. So always think about certain unusual situations, toxins also. Infection is common, but equally common are demyelinating disorders like ADEM. All of us know what is ADEM, acute disseminated encephalomyelitis. We know autoimmune encephalitis. There are inflammatory brain disorders called vasculitis. So these are groups of disorders. Now if you see, this autoimmune encephalitis is actually an extension of paraneoplastic encephalitis. So this is something we need to know. So this entity was actually known in elderly people when many people had lung cancers or breast cancers, started having encephalitis. So then they termed it as paraneoplastic syndrome and paraneoplastic encephalitis. And in fact, the first autoimmune encephalitis identified in children is after neuroblastoma. So what it could be? After neuroblastoma. So what it could be? It's a opsoclonus myoclonus syndrome. It's not NMDA encephalitis. So in 1920s, you had an influenza virus spectrum, and most of them had typical Parkinsonism. This was called as post-infectious Parkinsonism or encephalitis lethargica. So this is a movie called Awakenings. If you have time, you can see. Now, similar cluster of cases started happening in 2000s, again in UK. Now, when they investigated post-infectious Parkinsonism, they identified antibody against Streptococcus mitis. So this was a clue. There is probably certain antibodies against bacteria or viruses, which is causing encephalitis and Parkinsonism features, right? So that's somewhere in 2000s. Now, if you can see this graph, they are telling every year one new antibody is added, every year, okay? So paraneoplastic or onconeural antibodies were the one which were identified earlier, much earlier than your, right now what we are looking at, synaptic or ion channel encephalitis. If you see 2007, the first NMDA encephalitis was reported. It was reported in a young lady in a psychiatry ward. So this was a young lady told to have schizophrenia, developed a movement disorder, went into respiratory failure and coma. When they investigated, they found a ovarian teratoma, and from 2004, this case was first identified, 2004. To find out what antibody, it took 3 years, 2007. Okay? So 2004, 2 or 3 similar cases, young females with ovarian teratoma with encephalopathy. So they called a triad of encephalopathy, movement disorder, hypoventilation, and ovarian teratoma. In 2007, when they identified the antibody for the first time, within 2008, 120 cases were reported. Within 1 year, 120 cases were reported from 2007. You can just understand the importance. So this is a syndrome which is already there. This is not a new syndrome. Only that we have identified from last 10 years. So we are here for the last 10 years So many encephalitis, LG1, Casper, AMPA, GABA, Neurexin, IgNO5, so many. Every year they are telling one antibody is identified. So right now we have around 16 different types of autoimmune encephalitis. So like any particular immunity, when you have some trigger, we don't know what triggers it, either it could be a tumor or it could be an infection, the antibody reaches the lymph nodes, crosses the blood-brain barrier. But for NMDA encephalitis, there are certain germinal centers, that is lymph nodes within the meninges itself, that can produce the antibodies. So as far as CNS encephalitis is concerned, it is the CNS production of antibodies or clonal expansion which is more important. What is more practically important is that these encephalitis are broadly classified into two types. One that act against the extracellular antigens and one that act against the intracellular antigens. So these intracellular antigens like GARD or VGKC have poor response. But all those extracellular antigens like NMDA, Casper, LG1 have excellent response to immunotherapy. So the basics is that if you have autoimmune encephalitis with extracellular or synaptic receptor mediated antibodies, they tend to do extremely well. So let's see some case examples of case number 1. So this is a girl with behavioral change and sleep disturbance for 2 months, worsening behavior after fever for 7 days with 1 episode of seizure. She had irrelevant continuous talk, no meningeal signs. She had cognitive deficit in the form of oromotor dyskinesias, frontal lobe function defects. When I say frontal lobe deficits, it's a simple bedside test. If I ask them to copy patterns, they will find it very difficult to copy patterns. When I ask them to repeat certain things, they will find it very difficult to repeat, right? Arrange things in an order. If I ask them to arrange vowels and consonant, they'll find it difficult. So it's a very simple bedside test, and she had a lot of extrapyramidal syndromes like movement disorders. So what it could be, a 9-year-old girl with behavioral changes, which is followed by seizure and encephalopathy. So this is a very classical paradigm when we have subtle changes in the behavior or in the cognition like learning and memory, that is followed by a abnormal sensorium and movement disorder. So for all the PGs and younger doctors, please remember if you have a child with fever and altered sensorium and seizures, go back to the history. Maybe for the last 1 month they are having some behavioral changes and some memory changes. So subtle deficits in behavior and memory changes, which is followed by seizure and a movement disorder, is a very classical NMDA receptor encephalitis. So this is the girl. You can see she's just keeping the hand like this. This is called catatonia, right? So keeping hands in unusual posture. Initially it used to be, these children were used to told us having childhood schizophrenias, because slowness of movement, keeping hands like this, were all thought to be features of schizophrenia. So it almost closely resembles schizophrenia, right? So this was a child who responded very dramatically to IV steroids and IVIG. So what is this NMDA receptor encephalitis? It's an NMDA antibody mediated syndrome where the NMDA antibody goes inside the neurons. So the syndrome is like you are giving ketamine. So what happens if you give IV ketamine? Sometimes what the children do? They shout, they talk aloud, and they behave funny, right? So almost like a ketamine-like syndrome is NMDA receptor encephalitis because it is a NMDA antagonism. So multiple pathways, especially involving your brainstem, basal ganglia, and the frontal lobe. So these are the 3 key areas. Frontal lobe, I have memory problem. If I have basal ganglia, I have movement disorders. If I have brainstem issues, then I have breathing dysfunction. So these are the 3 key symptoms. So this was a case we saw in AIMS in 2011, right? Okay, sorry. Right, so I'm not able to see the cursor. Right, so you can have different type of movement disorders. It could be stereotypies, orobuccal dyskinesias, hypomotor thrashia, thrashing behavior, akathisia, catatonia, and perseveration. Right, I can't see the cursor here, right? Right, so if you have stereotypies and perseveration, the last 2 movement disorders, it favors much more of NMDA receptor encephalitis. So as I told you, NMDA receptor encephalitis can affect the brainstem where you can have autonomic instability. It can affect the frontal lobe where you have psychosis, catatonia, mutism, and rigidity. It can affect the brainstem where you have some semi-rhythmic movements. If it affects the pons, you can have breathing dysfunction. So if you see an MRI like this, what first comes into the mind? Temporal lobe involvement, unilateral, seizures. We always think about herpes encephalitis. So you can have an imaging like this, or you can have an absolutely normal imaging in a NMDA receptor encephalitis. Interestingly, it is found that around 2 out of 10, that is 20% of children with herpes encephalitis can also have coexisting NMDA receptor encephalitis. So initially those children with herpes encephalitis who did not respond or who had a new onset movement disorder were used to be called as chorioathetoid herpes encephalitis. Now they have found out they are actually cases of NMDA receptor encephalitis. You can see slowing in the EEG with a brush-like pattern. This is called as delta brush. Delta waves like a brush-like pattern is NMDA receptor encephalitis. You can clinically diagnose this, as I told you. So any rapid onset, less than 3 months of symptoms with cognitive dysfunction, psychiatric behavior, speech dysfunction, seizures, movement disorder, or autonomic. One of the 6. You need not have all the things because this is a staged illness. Symptoms comes in the first week, second week, third week, fourth week, and so on. So you can have symptoms coming over 1 to 2 to 3 months sometimes. So if you have a 3 months illness where you feel that the child is encephalitis, but it is not improving. Instead of improving, the child is showing new onset disturbances. Always think about NMDA receptor encephalitis. And if you show the antibody, then it becomes a definitive NMDA receptor encephalitis. So this was another girl who had type 1 diabetes mellitus with fever, with abnormal behavior, and she had refractory seizures. Her seizure started on day 4, it ended on day 44. 40 days of refractory status epilepticus, what is called as FIRES. Continuously ongoing seizures with initially normal MRI, normal fundus, with bit of rigidity and myoclonus. So she had this funny twitching-like movements in the eyes, right? Twitching-like movements. So she had a continuous seizures. So refractory status epilepticus model. What I want you to focus here is the MRI. So the MRI showing bilateral temporal is a very classical of mesial limbic. Mesial temporal lobe involvement is a classical feature of limbic encephalitis. So limbic encephalitis is another presentation of autoimmune encephalitis. This child had type 1 diabetes mellitus, which is again an autoimmune condition. So she had an antibody called GAD, glutamate acid decarboxylase. She was a GAD positive autoimmune encephalitis. She responded dramatically despite being 40 days on a ventilator on tracheostomy. Okay, so this child is now walking, coming to the OPD, going back to school, having a normal life again. She's on epileptic. Of course, she's having epilepsy. She's on 3 medications. But she's doing fine again. She's come back to life again. So autoimmune encephalitis are very much treatable. So as a pediatrician, when we should suspect autoimmune encephalitis? So part of what I told you, we suspect when it is a staged illness. It starts as one symptom and then goes on to the another symptom. It starts with some behavioral changes or with some cognitive changes. So subacute onset, progressive, multifocal neurological symptoms, a staged illness with movement disorder, seizures, behavioral changes, psychosis, CSF showing some pleocytosis, either a normal or an abnormal MRI. So a normal MRI does not rule out an autoimmune encephalitis, secondary worsening after improvement in encephalitis, and reasonable exclusion of other conditions. So how to manage? The first step is suspect. And once you suspect, you know, according to the age, certain encephalitis are common. In children, NMDA encephalitis is common, whereas in adults, we have LG1 and Casper and VGKC-related encephalitis. Right? You can have a lot of neurological symptoms like this. You can have facial-brachial dystonic seizures. Then it could be LG1. You can have even diarrhea. Diarrhea can be a clue of DPPX. You can have hyponatremia, which is a clue for LG1. You can have a stiff person syndrome, which is an indicator for glycine receptor. Like this, there are a lot of neurological signs. Interested ones can see an article called GRAUS, G-A-R-A-U-S, GRAUS, Clinical Classification of Autoimmune Encephalitis, freely downloadable, right? So some of the common phenotypes we see in children are NMDA receptor encephalitis, limbic encephalitis, encephalitis lethargica, opsoclonus myoclonus ataxia, and Rasmussen encephalitis, right? So once you suspect, you need to manage. The first and foremost rule in management is that do not wait for results to come as positive. It's not that you will wait and watch, let the antibody come, because almost 50% of autoimmune encephalitis have no antibodies. You cannot prove the antibodies, or antibodies can be shown later in a research labs. So once you suspect, you start a treatment, you have to taking decision factors like what is the risk factors and what is the situation, whether you have an appropriate ICU, whether you have a team, and so and so. Right? So this is a basic theme of treatment. If there is a tumor, remember I told you, this was a thing which came after paraneoplastic syndrome. So if you have a tumor, remove the tumor. If it is opsoclonus myoclonus, remove the neuroblastoma. If it's NMDA with ovarian teratoma, remove the tumor. Right? You can have even Hodgkin's lymphoma with OMA. So look for tumor. You may need a PET CT. You may need a whole body MRI. If there is a tumor, remove the tumor. Treat coexistent infections like herpes. First line treatment, second line treatment, and maintenance treatment. So first line treatment is usually steroids and IVIG. Second line treatment is rituximab and cyclophosphamide. And sometimes we need to maintain them with long-standing oral drugs like azathioprine and MMF. Always take a help. There may be experts who can help in such conditions, right? So steroids, if it's not improving, you can give rituximab. Rituximab is one of the best drugs because it's like only 4 weekly doses and it works directly at the production of your intrathecal antibodies. So when to escalate beyond first line? So not all children may not receive rituximab. The child improves, we can wait. And we start rituximab based upon various other features. I'm not going to that. So surprisingly, us being a tertiary center, of the 55 cases I've seen in last year, almost 50% were autoimmune and demyelination. So almost 25 cases I had of autoimmune and demyelination. It is as common. Being a referral center, the amount of infectious cases I had was less. But this is common, we should remember. So what happens in long term? What happens in long term? So 7 out of 10, or if you're lucky, 8 out of 10 children do improve. 70% to 80% have a good prognosis. Around 1 out of 10 can relapse again and again. So we need to monitor them. Most of these children do well, except limbic encephalitis and Rasmussen encephalitis, which can have a bad course. So this child did extremely well. This was the same child you saw first, right? This is my first child with NMDA. She's absolutely normal now, going to school. She did not have any ovarian teratoma. So my theme was a case which I told is toxin. The story is that this has been there before, but we have been identifying for the last 10 years. And I'm sure after 5 years, all the PGs will be telling, this is autoimmune, sir. This is Adam. So such much clinical classification and identification is possible, right? So the take-home message is that it's very common in children. High index of suspicion is required. Autoimmune encephalitis is very much amenable to treatment. And early and aggressive immunomodulation improves outcome. So this is from my teacher who always used to say, medicine is one field we learn and unlearn. And we relearn. Okay, so I'm also learning. I'm not an expert. I'm also learning so much about autoimmune. And everyone, this is an exercise we need to keep ourselves, preventing us from Alzheimer's disease and dementia. Right? So the only way we can prevent this is like conferences like this where we learn, relearn, unlearn again and again. Okay? So let us continue the same thing again and again. Thank you so much. Yeah.
Thank you, Dr. Akbar, for the excellent talk. Sir, the role of plasmapheresis and...
Yeah, so plasmapheresis depends upon the severity. If you have an extremely severe autoimmune encephalitis with brainstem symptoms like autonomic dysfunction, central hypoventilation, what is the concept? What is the concept? Only 2 concepts. You remove the antibodies and you stop the production of antibodies. And whatever antibodies you already there, you bind the antibodies, neutralize the antibodies. So we can bind the antibodies with IVIG. We can stop the production of antibodies by rituximab, which inhibits your beta cells. And we can extremely remove very fast with plasmapheresis. On the 3rd or the 4th cycle of plasmapheresis, almost 50 to 60% of antibodies can be removed. So for a severe syndrome, we can start plasmapheresis in the beginning itself. Otherwise, generally in children, we tend to go with plasmapheresis after a trial of rituximab, if it doesn't improve.
Your experience in Aster?
Yeah.
How long you have given plasmapheresis?
So we had used plasmapheresis not for autoimmune. I had used plasmapheresis for an NMO spectrum disorder. So we went almost gave around 6 to 8 cycles. One more autoimmune when it's not during Aster, where up to 3 months we gave. This was a child I told sir also. 9 months was non-ambulatory after NMDA diagnosed NMDA encephalitis, where rituximab was given but was not continued. The child only was on azathioprine. The family wanted, so after that we explained to the family that we can try plasmapheresis. 3 months we went around 16 to 18 cycles instead of our normal 8 to 9 cycles. And the child started ambulating again, movement disorder disappeared. Right? So this is one extreme scenario where even NMDA encephalitis can respond late also, unless there is a massive brain injury, significant brain injury. Right?
Thank you, sir, for the talk. Any questions from the audience?
Yeah, thank you for that informative talk. You mentioned that speech problems, behavior problems, psychiatric in NMDA receptor encephalitis. Will it persist throughout life? I mean, some cases after recovery?
Yeah, so it all depends upon the severity of the disease. Right? If it was a severe NMDA receptor encephalitis, some amount of cognitive dysfunction can present. Speech and all usually tends to recover. Movement disorder tends to recover. Some amount of cognitive dysfunction can present, but the numbers are extremely few and less.
Another thing is you mentioned IVIG and steroid together. So can we initially try with steroids and then if not improve?
Yeah,
it?
so I mean, if you go and see the classical Lancet article, it says that better to give combined together. Same principle applies for opsoclonus, myoclonus, ataxia also. You combine both together, first line. But if your situation is very mild, for example, I had a child who just presented with first episode of seizure and mutism for around 8 to 10 hours. NMDA was positive. It was a very mild thing. So we just gave steroids and the child improved. We did not go up to the IVIG line. So it depends upon the clinical scenario also. But preferably IVIG with steroids work better because IVIG helps in binding and neutralizing the antibodies quicker.
Questions? Any more questions?
So how frequently do you come across this autoimmune
Sir,
encephalitis?
Sir, I said it's a referral bias that I have in my hospital. So, I mean, even just talking today also post-lunch, it's probably an autoimmune sitting in my ED. That's the way it is, mutism, hyperactivity, irritability. The thing is, key is, are we suspecting? We'll easily call it encephalitis. But encephalitis is like, if there's studies to correlate this, generally encephalitis is, median time is very florid. Within third or the fourth day, child deteriorates. But if somebody deteriorates on the 7th day, 8th day, 9th day, think about autoimmune encephalitis. Like a child being referred right now in my hospital, already been 8th day and 9th day of illness with excessive crying, mutism, vomiting, CSF being normal, less than 5 cells. So autoimmune, numbers wise, I don't have the exact numbers, but for a referral bias in my hospital, I'm getting as more cases here.
Thank you, sir, for that excellent talk. Any more questions? So we'll go to the